In order for you to understand why the Envision platform is so amazing, you need to understand dry eye. This is the most powerful IPL device on the market. The fact that you've got an adapter that you can use on the lids to get rid of superficial telangiectatic vessels is really what the game changer is for this. RF is colourblind, so you can use this on every single skin type. If you have got blepharitis, the likelihood is you have an infestation of this parasite known as Demodex. One of the biggest reasons why I was totally sold by this was because it does everything that I want to treat dry eye. All right, so first of all, welcome everybody. Welcome Amanda and Nick. So my talk today is really just to introduce everyone to the Envision platform. So my name's Priya. I'm a oculoplastic consultant. I do work in the NHS still. I have a vested interest in female wellness. So a lot of my dry eye treatments and a lot of the work that I do outside the NHS is kind of menopause, dry eye kind of driven. I also have an aesthetic medical practice, so I also have a thing with skin, and I hope that if you take anything away from this, that you take away the fact that skin and dry are massively correlated together. If you're running an aesthetic service and you've got patients that have got skin problems, I guarantee you they've got an eye problem too. So it's worth just thinking about the questions that you're asking. I also am a KOL for Bausch & Lomb, and I'm a panel member, and every year we get together and we basically discuss how dry eye is actually affecting us globally. It is exponentially rising, and there are many reasons for that. One of them most obviously being screen time. And it's also affecting our kids because our kids are being taught on screens too. So this is going to be something that everyone is going to be talking about at some stage. Obviously a KOL for InMode, that's why I'm here today. And like I said, I run my own clinic, but I'm also very honoured to be starting up an eye service here at UMI. I'm an ambassador for Obagi and an ambassador for their Skin-Trinsic device. If you don't know this by the end of today, I really like to talk. Hence, I like to present and tell everybody about the things that mean a lot to me, which, as you'll learn today. But I also like to write, so I do publish in magazines and journals. Like to teach and train, so I train a lot of underprivileged kids who are trying to get into medicine. So I help them with kind of UCAS forms, interview prep, things like that. And I also train ophthalmology trainees and kind of help them navigate their way through the surgical pathway. So, in order for you to understand why the Envision platform is so amazing, you need to understand dry eye. And the actual definition of dry eye is so wordy, but basically it's multifactorial. There are lots of different reasons why you get dry eye, and it has multiple effects on different things on the surface of the eye which actually cause your symptoms in the first place. Now, from an ophthalmic perspective, the majority of patients that actually get referred to us have dry eye, and that's their reason for referral. I mean, my wait list in the NHS for a dry eye patient is about 18 months. And when they do get to me, the dry eye is so severe that we're putting them on biologics or cyclosporins or steroids. And that's why from a primary care perspective, it's really important that we identify these patients very, very early on so that they don't end up at that stage. Now, the stat of dry eye affecting between 14 to 33% of the population is completely incorrect. It's so much more than that. But the problem is we don't have a succinct way of measuring how dry eye is affecting people because people have it and they don't even realise. And like I said, by the time I see them, they're too far gone. There is an absolute financial burden, not just from kind of a clinical perspective, but also from a patient perspective too, because dry eye is not endorsed by the NHS. You have to go and buy your drops yourself. People are buying eye bags and all sorts of things, trying to get it under control. But the problem is that not very many things work. There's a problem with patient compliance, and ultimately it's just a downward spiral. So I'm sure each and every one of you have had one of these symptoms. So, you know, like at the end of the day, kind of a sore red eye, feeling like you've got a lash in your eye, but there's nothing in there, a burning sensation, lids being a little bit itchy, sensitivity to bright light. The blurry vision or visual fluctuation is what I had when I actually made this presentation. Like you get towards the end of it and you're like, your vision starts to zone in and out, or you get that kind of boring feeling at the back of your eye where your eye feels tired. These are things that everyone has had an element of at some stage. And if you've got symptoms, you absolutely have dry eye and we need to treat it. So there are lots of different causes. If you have any kind of inflammatory condition that you've been diagnosed with, from IBS to thyroid disease, you're going to have an element of dry eye. Any form of eye surgery. The cohort of patients that I see in my corneal clinic who have had LASIK and we are struggling to get their dry eye under control is just, I mean, it's unfathomable. Cataract surgery massively causes dry eye. And actually, the patients who are being listed for cataract surgery come in with dry eye and it affects their post-surgical outcome. Any form of autoimmunity, so like Sjogren's, rheumatoid, but the biggest thing for me is hormonal imbalance. Any patient over the age of 35 that is starting to have symptoms of perimenopause, they're on a bandwagon to dry eye. Systemic and topical medications, there is a whole list. But the ones that I feel like we need to pick out from an aesthetic perspective are your ladies that are coming in with beautiful long lashes. 9 times out of 10, they're on a lash serum, contains a PGA. You have to ask the question. Any course of Roaccutane from when they were a teenager has obliterated the glands in their lids. Again, it's causing dry eye. And it's also worth asking, how are they putting on their retinol? I had a patient actually that I saw here on Wednesday, and she was like, oh, you know what, I use retinol every day. I was like, well, how do you apply it? She's like, I just whack a whole load on my hand and I just put it everywhere. She's obliterating her Meibomian glands. It's causing her dry eye. So these are all things that we need to be asking, even from an aesthetic perspective. And like I said, most importantly, it's our environmental factors. We're all on a screen all the time. We're blinking normally when you're on a dog walk and minding your own about 23 blinks per minute. The minute you pick up a screen and you start concentrating, that goes down to 8. And we all have an unstable tear film. So your tear should last on the surface of your eyes for about 10 seconds. If you have a healthy tear film, your eyes are not going to dry out. But I guarantee you've had some of those symptoms. You've all got an element of dry eye. Your eyes are drying out the minute you turn on a screen. And this is just, like I said, a downward spiral that we need to treat. So like I said to you before, there is a huge correlation between dry eye and skin. And it's important that we understand the structure of the skin, your basic kind of epidermis, dermis, subcut fat, because that's really important to understand how the Envision platform supports treating dry eye and blepharitis. Now, when it comes to dry eye, I kind of like simplify it in my head into kind of early asymptomatic. They're the patients that we need to be getting in and treating. By the time you get to the stage in the NHS where you've got atrophy, we are troubleshooting, trying to give patients a little bit of quality of life back, because there are some patients that I've seen. I mean, a couple of weeks ago, I had a 37-year-old, lady. Her dry eye caused a psychosis. She can't leave the house, has to wear glasses, had to quit her job. She was put on antipsychotic medication. One of the side effects of the medication is dry eye. So she is on this vicious cycle. And it's really, really difficult just to give people their life back. And it's really important that we realise that dry eye is not something that it's just put some drops in and you feel better. It's affecting people's quality of life, and it's leading even to suicide. So when I'm talking about dry eye, the structure that I'm actually talking about is the cornea. So that's kind of a transparent dome structure which sits over the coloured part of your eye. Now, the reason that it's transparent is that it doesn't have a blood supply. It gets all of its metabolites in order to function from your tear film. So if your tear film is dysfunctional, the cornea is being starved of oxygen and metabolites, and then it affects your vision because you can't see very well. But also it sends messages to your brain which gives you all those pain symptoms. But the other thing is that when you have severe dry eye, you end up with your eyes being quite watery, because it stimulates reflex tearing. So patients will come in with profusely watery eyes. They've been told by opticians, oh, it's because your tear ducts aren't working very well, you've got a blockage, but actually they've got severe evaporative dry eye. You put them on decent lubricating drops, the watery gets better. So your tear film is actually made up of 3 layers. So you've got your outermost layer, which is your lipid layer, and this is what we're treating with the platform. So your lipid layer is what I like to call your protective armour. It's protecting the water part of your tear film from evaporation. And if you've got a decent lipid layer, it's actually the surface that the light is going to hit so it can bend to go inside the eye for processing. Now, if that lipid layer is deficient, which is what happens when you have something called blepharitis, it affects what you see. And that's the reason why you get the fluctuation in vision. So where you're staring and all of a sudden your vision gets smeary and then you blink a few times and it clears, you're just smearing that fresh oil over the surface, and that makes the refractive surface better. Now, your aqueous layer is your middle layer. That's kind of your water layer. each drop of your tear film, or each drop of that aqueous layer, contains 1,500 antibodies. So if you're evaporating away a lot of that water layer of your tear film, you're more likely to get infection. So that's why patients who are contact lens wearers, who have got a really disrupted tear film, they're more likely to end up with ulcers on the surface of the eye, and then they scar and then they lose vision. The last layer is your mucin layer, and that's a bit like the glue. It just kind of anchors the water part to the cornea, so that the whole structure just kind of sits one on top of the other. So there are different elements which actually produce your different layer of tear. So your lipid layer is produced by your Meibomian glands, and that's what we treat with the Envision platform. So your Meibomian glands are like columnar glands. They kind of start off in your lower lid just above your orbital rim, and they point upwards and they open just behind your eyelashes. And on the top lid, they start at your skin crease and they point downwards and again open behind your eyelashes. Now, your aqueous layer comes from your lacrimal gland. That's located just behind your orbital rim at the top here. And then your mucin layer actually comes from the eyeball itself. So when your tear film is dysfunctional, the kind of things that I see are like your bottom picture, where your cornea is starting to become vascular. And that's because when the cornea becomes severely hypoxic, it starts to draw in blood vessels in order to try and survive. And when you get to that stage of life, it is really difficult to get a handle on it. So going back to Meibomian glands, which I think are super important because you really need to understand what we're treating with the platform. So it's actually 85% of all dry eye is actually caused by dysfunction of these glands. Now, like I said, they're columnar. They sit in a structure known as your tarsal plate. And how they work is that they're on its kind of superficial surface, you've got the orbicularis oculi muscle, so that sits in front of your tarsal plate. So every time you close your eye as part of your blink, you put pressure on the Meibomian glands. The Meibomian glands will excrete a tiny little micro droplet of sebum, which is the oil, which sits in between the two lids which are touching together as you've closed your eyes for your blink. Then when you open your eye as part of your blink, that oil kind of coalesces, a bit like windscreen washer, and coats the entire surface. Now you've got about 24 glands in your top lid and your bottom lid. In order for you to have or to not have dry eye, you need 5 functioning glands. So that's why having a piece of kit that can reignite some of these Meibomian glands is a game changer for patients who have got quite severe dry eye. So blepharitis is really the name of the game. So this is what we're really trying to treat. So when you have blepharitis, all that really means is bleph means lid and itis means inflammation. So when you have inflammation of the eyelids, they end up causing a problem with the glands themselves. And I kind of liken the pathology of blepharitis a bit like a cork in a wine bottle. So that sebum, that oil, at its most superficial becomes solid. And that's what we see when we look through a slit lamp. We can see little plugs at the kind of the shelf of the lid. And that gives me an indication that there's a blockage, the sebum is dysfunctional, and that in itself causes inflammation. Now, when you have inflammation, you release inflammatory mediators, and then that fuels this problem. Now, blepharitis is something that we also see in rosacea patients. So if you've got patients that are coming in with like kind of red, inflamed telangiectatic skin, they've also got dry eye, and you need to be treating both. Now, the longer they have the inflammation form, they end up with atrophy of the glands, and the glands tend to start to just die away. The other thing that I tend to see, especially in kind of your perimenopausal cohort and above, is they get kind of recurrent chalazion. So they come in with like lid lumps. And like, you know, I've been fine for all these years. All of a sudden now I'm starting to get all these lumps on my lid and I can't seem to get rid of them. It is down to the fact that the glands are dysfunctional. The other thing, which patients hate me mentioning, is an infestation of Demodex. So if you have got blepharitis, the likelihood is you have an infestation of this parasite known as Demodex. They like to accumulate where you have chronic inflammation. Rosacea skin, they have Demodex all over their face. Where they accumulate, you can see them on a slit lamp because you can see their exoskeleton, which have clung to the lashes themselves. They have a lifespan of 4 weeks, and they shed their exoskeleton when they die. They tend to come alive at night time. That's when they start to move around and mate. You find that patients find that their lids are a little bit itchy at night time. They wake up in the morning, they have quite severe dry eye. and this is something that we do need to treat. So this is basically just a summary. So basically, like I said, blepharitis is caused by a whole host of things, but skin is really a big deal. Patients who've got periocular eczema, dermatitis on their skin, someone who's quite sensitive and gets allergic reactions, they have all got elements of dry eye. These all need to be reviewed and treated. So like I said, going back to hormones, because obviously that's something that I really am passionate about, the fluctuations in estrogen level is what actually causes the meibomian glands to become dysfunctional. So what happens is that when patients go through perimenopause, it's not that their estrogen level is down through their boots. They have days where it's really high, days when it's not so high, and that kind of fluctuation causes a change in the composition of the mebum, so that oil, where it starts to become solid at body temperature. So then that encourages kind of the plugging, the development of chalasia, and then inadvertently the glands start to atrophy, and then they get this kind of fueled inflammatory process. And I mean, in my NHS practice, I literally see about 100 patients a week with severe dry eye. About 65–70% of them are postmenopausal women. The other thing that it's important to know is that perimenopause changes your skin. You're losing collagen everywhere. So you get volume loss, that causes a change in the position of the eyelids. So where your meibomian glands were sat in the correct anatomical position, they can start to point outwards or point inwards. So when you're getting that blink, you've not got the coalition between the upper and the lower lid. So actually treating their skin is another thing that we should all be thinking about when it comes to treating dry eye. The other thing is that during perimenopause, we become increasingly sensitive to products. So you'll have patients that will come in and they'll be like, I've been using this product for decades and all of a sudden I can't use it anymore because I start to break out, or my skin is more sensitive. That in itself has an effect on the ocular surface too. So let's move on to the platform itself. So the Envision Platform, and one of the biggest reasons why I was totally sold by this, was because it does everything that I want to treat dry eye. So the Forma-I and Lumecca-I. So Forma-I is bipolar radiofrequency. You've got Lumecca-I, which is your intense pulse light therapy. Both of those are ergonomically designed to treat the globe itself, so you can actually treat the eye. But also the beauty of the device is that you're treating skin too, and this is what's the game changer. Now, we have used IPL to treat dry eye for a very, very long time, but most of the protocols are kind of a W kind of treatment where you're just treating the cheek area in order to reduce the inflammation. Lumecca-I allows you to treat the lids themselves where you have that telangiectatic vessel as long as you're wearing stainless steel corneal shields. Now, what makes Envision more special is the bipolar radiofrequency. And the reason for that is we've never really combined the two. And this is what changes how we treat dry eye. So let's talk about Lumecca-I. So this is the most powerful IPL device on the market. And the fact that you've got an adapter that you can use on the lids to get rid of that kind of superficial telangiectatic vessels is really what the game changer is for this. Now, what IPL does, or how it treats, is it treats the epidermal layer. So we're very superficial when we're using IPL. Now, there are two handpieces that InMode do. You've got your 515 and your 580. I personally, in my clinic, have only got the 580. The reason being is that I can use it on eyelids themselves without worrying about the fact that the power is so much. Now, it's still very powerful and it does exactly what it says on the tin, but 515 tends to be reserved for your kind of classic rosacea patients, and I wouldn't use that on the lids. I would only use that on the malar region and the rest of the face. Now, I mean, I'm sure people will debate, but from my perspective, I would never IPL anyone over a Fitzpatrick type 4, but even a Fitzpatrick type 4 I would be massively conservative with. Now, the reason being is that the skin will burn, and how IPL works is that it gets absorbed by kind of pigment in the skin, so that's either melanin or it's the hemoglobin from your red blood cells. Now, if you've got an Asian skin type or darker, you're going to absorb too much energy and then you are going to end up burning, and then that fuels kind of hyperpigmentation. It's just not worth it. The spot Lumecca, so the spot IPL, because it's spot, it's very directed, and that's why you can actually use it right up towards the lash margin. So your standard IPL, we've always taught that you've got to stay about 2 millimeters away from the root of a hair, because there's always a risk that it's going to get absorbed into the root of the hair and then you would lose that hair follicle. But actually with this, you can go all the way up to the lash margin because it's so directed that it's not going to cause lash loss. Even though it doesn't have the calling tip with the IPL, with the spot, patients actually, also in my experience, I found that they find the spot so much more comfortable than the big kind of crystal IPL that we use on the cheeks. It's not snappy, so it's a lot more comfortable when it comes to the lids themselves. So like I said, how IPL works, it gets absorbed by pigment, and with red blood vessels, it literally just shatters the vessel. And you will see that when you've kind of struck gold and you've hit the vessel, it gets darker when it comes to the surface. It does the same if you're also treating pigment. And the beauty of the device is that you can also treat skin. So not only are you treating lids, you've got the capability of moving into more of an aesthetic space where you can actually get rid of sunspots and kind of pigmentation from sun damage. And again, once you've hit that melanin in that superficial layer, again, it will come to the surface, it will look darker, and that pigmentation fades away. So with Lumecca-I, there's not really much more I want to say about that. Like I said, it's as long as you are sensible and you're using corneal shields and you're protected as the operator, it's an actual game changer because you can really treat those vessels on the lids themselves. So what does Lumecca actually do? What does IPL actually do? So aside from getting rid of the blood vessels, IPL gets absorbed by the exoskeletons of your Demodex parasites. So by treating very close to the lash margin, you can actually eliminate an infestation. It also gets absorbed by cells which produce ATP, so your mitochondria, and that in itself causes neocollagenesis. So you're actually giving patients more collagen in their skin and reforming it. Because we're reducing the inflammation and we're changing the inflammatory cycle, the osmolarity of your tear film gets better. And it also very lightly warms the Meibomian glands. So up until now, like I said, we've only been doing IPL. So with IPL, what you're doing, or what the treatment protocol is you would IPL them and then you would compress the glands in order to express. But the thing is you're not warming the glands enough in order to get really decent expression. And that's why RF is your game changer. The RF is called Forma-I. It's bipolar. And it's kind of your bulk heating. So this is what's really going to melt that mebum and allow you to get a decent expression. Now, because it's bipolar, you don't have to wear pads on the back of the shoulder or the back of the neck, so the energy is not traveling through the globe itself. And that's why you can do this RF treatment without needing any ocular protection. So you can actually put this on the eyeball itself up to the lash margin, and it's not going to cause any intraocular damage. So this is Forma-I, so this is the slightly bigger handpiece, but there's a feedback mechanism. So about 1,000 times a second, you're getting feedback from the heat, the contact, and it gives you an idea of whether you're actually doing a decent treatment. Now, the beauty of using radiofrequency is that it massively stimulates neocollagenesis, so you're increasing the thickness of that dermis, and that's why Forma-I is so great. So not only does it treat dry eye from the fact that it will stimulate some of those Meibomian glands which are on their way out and dying and re-kick them so they can start working again, but it also helps with periocular skin health. So it will help with your fine lines and wrinkles. It can also help reposition the eyelid ever so slightly because initially you get a contraction of collagen which will give you a slight lift. But inadvertently, I've had very good aesthetic results from this as well as with their dry eye symptoms. RF is colourblind, so you can use this on every single skin type. So like I said, IPL, mainly Fitzpatrick 1, 2, 3, (4), but Fitzpatrick's 5 and 6, you cannot IPL them, but you can RF them, and they will still get an expression, you're still stimulating their Meibomian glands, and you will still be helping their dry eye. So this basically is just going over your monopolar and bipolar. So if you were using a monopolar RF, you would absolutely need to wear a protective eye shield. But with Forma-I, you don't need to. With the IPL, like I said, it treats your telangiectasia, but you're doing it directly. That's why Envision is different. It eliminates your Demodex, and it's mildly heating those glands. Whereas with RF, you're stimulating collagen. You're actually doing something to regenerate these glands, but you're heating them so then you can go on and express. Now, expression isn't something that is necessary in the sense that it's going to make the treatment massively better. What you're doing when you're expressing is you're looking at the quality of that mebum. So initially when I do the treatment, maybe for the first or second treatment, I'm not getting much that's coming out. But then by treatment number 3 and 4, I'm starting to see things because the glands are re-kicking and they're starting to work better, and that mebum is improving in quality. And so then you know that the glands are actually functioning. There is homework to be done after this. It's not a one-stop shop, but if they keep on top of their condition, then they don't end up with the severe dry eye. They don't end up in my NHS service. So the protocol tends to be, which is a bit different to when you're treating skin with IPL, is that it doesn't matter what you do as long as you're expressing after Forma-I. So as long as you radiofrequency, because you're heating those glands to 43 degrees, and then you express, that's fine, and you can IPL after that. When you're treating skin, say for like rosacea, ideally you want to RF first and then IPL, because you dilate those vessels, you're just going to get a better response. But for a dry eye treatment, it doesn't matter, as long as you're doing an expression after doing the radiofrequency. So on average, when I consult patients, I'm like, it's roughly between 3 to 4 sessions up to 4 weeks apart, depending on how you respond. So when I never treat on consultation. So I send them home with a warm compress. I do like the PEEP wand. It's kind of a handheld device with vibration and heat, and it basically just starts to soften that mebum. So by the time they end up coming in for a treatment, they've already started this process. I put them on Zocular foam, which is an ochre-based lid foam, and the reason I do that is that it massively helps with Demodex. If they've got rosacea, I actually get them to use that on their entire face, because I find that by reducing the concentration of the Demodex, then they actually respond a lot better. Omega-3 supplements is a good shout, only because it improves the quality of their mebum. I mean, there is some evidence to say that it does, but any little bit helps. Lubricant-wise, I tend to pick according to what I see. So if it's a patient that's got, riddled with blepharitis, and they're kind of perimenopausal, and they've got very poor tear film, and it's definitely evaporative and only evaporative dry eye, I tend to put them on a lubricating drop that contains mucin, so something like Hydromed, or something that contains trehalose. But if it's kind of just, they're very, very early on in the stage, blepharitis is not too bad, but I'm thinking more hylo. So more of a lubricant with less thick stuff in it. I do a lid examination too, because one of the other reasons that patients have quite severe dry eye is that their lids aren't shutting completely. It's either because they have an incomplete blink reflex, which a lot of people have, where their top lid comes down but doesn't meet the bottom lid, so they get a slither which is not being lubricated, or when they close their eyes, their lids aren't meeting completely, so their lids are staying slightly open when they're sleeping. And if that's the case, then I do send them home with something known as an eye seal to keep the lids shut so that they don't get that evaporation when they're sleeping. Post-treatment, because they've been IPL'd, they need to use a cold compress for 2 to 3 days afterwards. And then after that, they go back to using their PEEP wand, and then their Zocular foam with their lubricants. And I also send them home with some sunscreen. So I use the Obagi Sun Shield Factor 50 because it's mineral and chemical based. And they should be on a sunscreen if they've been IPL'd, even if it's a part of their face. And again, if their lids aren't closing completely, then they have to keep going with their eye seal. So let's have a look at some befores and afters. So I also, as an oculoplastic surgeon, don't tend to cut out very many chalazions anymore in my private practice. This was a patient that came to see me. This was immediately after her treatment. So Forma-I on its own, 10 minutes, and you can open up that gland, express, and you treat their chalazion. This was 4 weeks after first treatment of just Forma-I. So for those patients that come in for kind of periocular Botox, and you know that you can't treat kind of inner kind of corner with those fine lines because you've got your inferior oblique muscle which sits just underneath the globe, and Botox will spread. And if they get spread with toxin and you paralyze that muscle, they end up with a torsional double vision, so everything looks slightly tilted. It's horrible for the patient. They have to wait 3 months before it wears off, and they can't drive for that amount of time. So you never treat kind of medial to your mid-pupillary line, but you can Forma them, and that will absolutely treat those fine lines and wrinkles. It also helps with lymphatic drainage too. So Lumecca-wise, just from a skin perspective, is amazing. It really hits those blood vessels, it will shatter them, and it will get rid of that malar kind of inflammation. And really, when we do treat with IPL, I do treat most of the time full face and lids if they look like this. I don't just do kind of the cheek region, I just do the whole shebang. And all of my patients will also get skin scanned just so that I can see where their baseline inflammation is. So I get them to close their eyes and I look at the whole face. And if they've got vessels which are deeper, that are everywhere, then there's no reason not to treat the whole face. You may as well do the whole thing. This is what happens with pigmentation. So, you know, it will all come to the surface and it just flakes away. And sometimes pigmentation is what fuels their inflammation. So if you treat them with Lumecca, actually the inflammation in the skin generally gets better. The middle picture is there is an element of downtime. So you'll find that when you're hitting the actual pigment cells, everything gets a bit darker. So they will look a bit sun-kissed, some of them can look bruised, and then everything will just fade away. But you need to reassure them, but also during the consent process, warn them that, you know, if they've got a big event, I wouldn't be Lumecca-ing you if you've got quite a lot of pigmentation and lots of telangiectasia, because there will be some downtime. So Morpheus 8 is an interesting one. So when I look at patients' faces, I'm also looking at what their lids are doing, like I've said. And by doing a good Morpheus 8 treatment, you can improve the lid positioning because you're improving that scaffold. But also people are not coming into my clinic necessarily just for dry eye. They're coming for periocular rejuvenation too. So there is an absolute space for Morpheus 8. And you can see it makes a huge difference to A, what they look like, how they're feeling, but they will definitely have an effect on dry eye from a lid positioning perspective.
Can I just say something?
Yeah,
the very first patient that we treated with Morpheus 8, she had runny eyes like anything, she always used to say. And after Morpheus, she said, I don't know what's happened, but my runny eyes have completely gone.
So I've seen that. So if you're treating, if you're treating periocularly, obviously not over the globe where you've retracted the lid.
The prime around.
Yeah. What happens is where you've got that remodeling in the dermis of all that collagen, where your meibomian glands should sit naturally there's no room for maneuverability. So if you've got laxity in your skin and then those meibomian glands move slightly, but alongside that you've got your puncta in the inner corner, which should also be sat like abutting the globe. So when you go off and do a Morpheus 8 treatment and you're treating the dermis of the skin, reforming that collagen, everything goes back to its normal anatomical position. And so it may just be that just by moving that tissue 0.5 millimeter by treating them, you've solved their watery eye. And that's why it's really important that even from an aesthetic perspective, we're looking to see where are things, where is your lid, and why have you got symptoms that you've got? Because it's amazing that something as simple as this that we're doing for just rejuvenation of skin can massively change someone's quality of life, aside from an aesthetic perspective.
People with malar edema,
Yeah.
does this help with that?
With what respect?
Just big festoons and big...
Well, you need to find out why they've got festoons in the first place. So it could be a cardiovascular thing. So I always tend to, when I see them in my practice, I obviously do a history and whatever. Forma can help with malar edema because how you're moving the forma, you're encouraging lymphatic drainage. I'd be a little bit cautious if they've got massive festoons with Morpheus 8 because you've got to be thinking about where those needles are hitting. But it can make a difference, but it's a case-by-case thing. But I would tend to err on radiofrequency to begin with rather than going in with needles like from the off. Just depends on the cause of their pathology. The other thing is acne. Morpheus 8 is great for acne-prone skin, especially not just from a scarring perspective, but I've also found that where you're using the radiofrequency heat, it also has an effect on those kind of sebaceous glands that are overproducing sebum. And that's why microneedling with radiofrequency can actually make a huge difference to acne-prone skin. So it is something to kind of keep at the back of your mind when you're kind of treating, because obviously acne, loads of sebum, lots of inflammation, absolute dry eye. Massive correlation between the two. That is it.